Well, greetings again from Chapel Hill, North Carolina. This is the last day of another fantastic PHC. I will summarize a few highlights from today's meeting. Here are my disclosures. We heard several great lectures regarding the pathophysiology, diagnosis, and outcomes of NASH. Professor Pinzani provided a master class on the pathophysiology of this disease. NAFLD is the hepatic manifestation of the metabolic syndrome, a clinical entity characterized by metabolic stress and inflexibility leading to dysregulated glucose and lipid metabolism. The peripheral mobilization of free fatty acids to the liver associated with de novo lipogenesis and reduced beta oxidation leads to lipotoxic load and chronic oxidative stress. Progressive fibrogenesis leads to cirrhosis and predisposes to the early development of hepatocellular carcinoma. Genetic polymorphisms play a key role in the establishment of NASH and its fibrogenic evolution. Mutation of the PNPLA3 induces a marked increase of hepatic stellate cell fibrogenic response to oxidative stress. So all of this information can help inform the ongoing search for effective therapeutics and set the stage for further discussions throughout the day. Professor Castera provided important information about the clinical diagnosis of NASH and fibrosis staging in these patients. There are several take-home messages that are worth mentioning. CAP is a promising point-of-care technique for rapid and standardized steatosis detection. However, it's a bit suboptimal for steatosis quantification as there are no consensual cutoffs as shown here. MRI fat fraction is the most accurate technique for detecting and quantifying steatosis and outperforms CAP. However, it's more suited for clinical trials because there's very limited applicability at this time and it is rather costly. Of course, ultrasound remains the first line tool to diagnose steatosis within the liver, although we have to recognize it has many well-known limitations. We're all hoping for non-invasive tests that can differentiate NASH from simple steatosis. However, as pointed out by Professor Castera, currently none of the non-invasive tests are sensitive nor specific enough to accurately differentiate between these two entities. While liver biopsy remains the gold standard for diagnosis of NASH, in usual clinical practice, this may not be performed on all patients because of the cost, the lack of patient acceptance, and also resource availability. There are issues with interpretation that is not standardized across all academic or community sites. Thus, the continued pursuit of NITs is very important. So for fibrosis staging, I think that in general, non-invasive tests do much better. But ultrasound remains the first line tool for detecting NAFLD. Liver biopsy is still very important for diagnosing NASH, but as mentioned, has limited utility given the sheer numbers of patients with non-alcoholic fatty liver disease. Some of the non-invasive tests for fibrosis are such as FIB4, the NASH fibrosis score, ELF, elastography are the most accurate and validated NITs for diagnosing advanced fibrosis. So in clinical practice, the optimal strategy is sequential use, starting with readily available testing such as FIB4 or NFS to rule out more advanced disease, and then going to more specialized testing such as elastography in certain circumstances. Professor Castera also proposed a nice visual shown here of a stepwise algorithm for evaluating patients with suspected NASH. It begins with the practitioners on the front lines who are most likely to encounter these patients in routine care, not necessarily the referral center. So that's the general practitioner or the primary care physician or even the diabetologist. So of course, rule out other causes of liver disease such as alcohol or viral hepatitis is important. And then establish the extent of fibrosis using some of those non-invasive tests that we just discussed, and consider referral to a hepatologist for those patients who have evidence of intermediate to high risk for advanced fibrosis. Professor Paradis provided a state-of-the-art lecture on the pathophysiology, on the pathology of NAFLD or NASH, which detailed many of the complexities of understanding the pathology of these diseases and how they're applied in clinical practice. Our next section talked about the multidisciplinary management of a systemic disease, and it brought together hepatologists, diabetologists, and surgeons who may be called upon to manage patients with non-alcoholic fatty liver disease in a multidisciplinary manner. Professor Cardoso from Brazil discussed a stepwise approach to how to manage these patients. Seems like all the steps begin with evaluating for alcohol use. So careful questioning and perhaps using a standardized screening tool is important to exclude alcohol as an underlying cause of fatty liver disease. The next step is evaluating for the presence of comorbidities, ruling out other causes of liver disease such as viral hepatitis, the use of hepatotoxic medications, evaluating for less common autoimmune diseases or other metabolic diseases such as hemochromatosis or alpha-1 antitrypsin deficiency. Professor Cardoso also stressed that cardiovascular disease is an important cause of mortality and morbidity in patients with NASH. Overall, the two major causes of death which were observed in a cohort that she described included coronary artery disease and liver-related deaths, both comprising between 25 and 30% of all deaths reported in this cohort. Similarly, cardiac mortality was not different between NASH and non-NASH groups, and patients with NAFLD and type 2 diabetes were at highest risk for overall mortality as well as liver-related mortality. So all patients with NASH should be evaluated for these risk factors and screened appropriately and managed for cardiovascular disease. This may include treating patients with statins for hyperlipidemia, for example. There remains some hesitancy to use a statin among general practitioners because of their perceived toxicity to the liver. But of course, we know that this is not true, and that statins may actually be beneficial in many patients with liver disease are being investigated as a treatment for all causes of cirrhosis and improving outcomes in those patients. And we should stress those facts to our primary care colleagues so that they can utilize statins when indicated. Regarding management, Dr. Cardoso also stressed that the next step is lifestyle changes. So controlling hypertension, diabetes, hyperlipidemia, and losing weight will go a long way to mitigating the negative effects of NASH. Dr. Cardoso called this step 4, but I suggest perhaps we call this stepping away from the refrigerator. She notes that the Mediterranean diet has been recommended as one of the best diets for the treatment of NAFLD by various clinical practice guidelines, and also has the greatest evidence to prevent and manage metabolic syndrome and its components, particularly type 2 diabetes and cardiovascular disease. So after evaluation and lifestyle changes, it's only then that one should consider using medications. So step 5 can be considered for select group of patients with NASH. Treatment with agents such as pioglitazone and vitamin E have benefits on subgroups of patients with NASH and can be considered in certain circumstances of biopsy-proven NASH, for example. Of course, the search for specific therapeutics is well underway, and later speakers provide some exciting details in this regard. Professor Romero Gomez discussed the importance of accurate fibrosis detection using non-invasive tests. He described a number of NITs that can be calculated from conventional, readily available lab tests like FIB4 or the NAFLD fibrosis score. These are readily available through routine blood tests in your clinic and should be utilized. Other methods, as I mentioned before, such as elastography, require specialized equipment, which may not be available in environments of limited resources. So one theme I think you'll notice that across all our speakers is that fibrosis assessment is important in order to understand the prognosis, as well as to get patients into suitable surveillance programs for hepatocellular carcinoma when there's evidence of advanced fibrosis and cirrhosis. So some additional take-home messages from Professor Gomez-Romero's presentation is shown here. Fibrosis determines the prognosis of NAFLD patients and is the main therapeutic target. Combining education, various tools, and communicating well with the patient combines to make an effective program to detect NASH and refer patients at risk for advanced fibrosis from non-hepatology clinics. Common to all of the discussion so far is that lifestyle interventions can promote weight loss and fibrosis regression in patients who have significant advanced fibrosis. OCA is the only compound with a significant but modest effect on fibrosis regression that's been shown in a phase 3 randomized controlled trial. There are other promising candidates that are going to be discussed in detail with some of the other speakers, but these are still undergoing additional testing, similar in a manner similar to OCA. And ultimately, precision medicine and innovative trial designs may help improve the overall efficacy and efficiency of treatments for NAFLD. Professor Rodin, an endocrinologist and diabetologist, brings some unique perspectives to the management of patients with NASH. He provided an excellent overview of the complex mechanisms that are shown here associated with NASH pathogenesis and how the various targets can be exploited to better treat this disease. He emphasized the importance of looking at NASH as a systemic disease, particularly among patients with diabetes in whom it may be overlooked, and the need for greater awareness among diabetologists to evaluate and co-manage this disease with hepatologists. Finally, in this session that brought together the multidisciplinary approach, Professor Patou, a bariatric surgeon, provided his perspectives on the impact of bariatric surgery as a treatment for NASH. This slide shows the resolution of NASH several years after successful bariatric surgery. He presented recent data on an important prospective cohort of 180 patients who had biopsy-proven NASH, who then underwent bariatric surgery. You can clearly see the trends over time to the disappearance in NASH in 85% of patients after 5 years of follow-up, and perhaps more importantly, to the regression of fibrosis in the vast majority of patients with NASH who underwent bariatric surgery. So the take-home message is that NAFLD can regress after bariatric surgery. NASH often disappears in more than 80% of cases, and that liver fibrosis demonstrates regression in the study that he presented 5 years after surgery. The impact and the applicability of bariatric surgery for NASH is still being evaluated in large multi-center studies and also in randomized trials. The next state-of-the-art lecture was provided by Professor Arun Sanyal, who talked about new drugs for NASH. Professor Sanyal reinforced again the importance of considering NASH as a multisystemic disease that has myriad effects on other organ systems. He presented in great detail a remarkable review about the multiple mechanisms of action for NASH drugs and what their potential activity is to treat NASH, along with some very exciting clinical data. He provided this exciting information regarding the results from some recent clinical trials. He examined the potential role of combination therapies that have complementary mechanisms of action. And he also looked to the future and challenged all of us to modify the regulatory pathways, to innovate trial design, to develop methods for greater precision and histological assessment, including dynamic assessments of histology, and, as mentioned by our other speakers, develop precision approaches for patients with NASH, because one size may not fit all of those patients with the disease, particularly when they have different multi-system manifestations. Our next section examined the frontiers of management of end-stage liver disease. Professor Tabot described the different categories of hepatic encephalopathy and focused on the premise that non-clinical HE was underdiagnosed. He discussed the challenges associated with that diagnosis and some of the implications for patients. His take-home messages, his presentation and take-home messages make the case that non-clinical HE is often underdiagnosed, that attempts should be made to diagnose that, and that additional screening tests are needed that are easy to perform and can be done in a viable clinical scenario. Therapeutic tests utilizing a therapeutic trial of treatments for minimal hepatic encephalopathy or non-clinical hepatic encephalopathy may be one good option, and that there are a number of unresolved questions in this area, particularly whether or not how reversible this mild spectrum of HE is. And finally, Professor Buers gave a wonderful presentation regarding the diagnosis and management of cholangiocarcinoma. He reminded us of the different distributions, the intrahepatic cholangiocarcinoma occurring in 10 to 20% of cases, the perihilar cholangio occurring in 50 to 60% of cases, the majority that get diagnosed with cholangiocarcinoma, and distal cholangiocarcinoma in the remainder. Each of these represents unique diagnostic and management challenges. He presented a nice algorithm, a schematic about the current management of patients with cholangiocarcinoma, again, requiring a multidisciplinary approach, tried to determine if the disease is resectable with curative intent provides the best chance for long-term survival. But unfortunately, this is the least frequent outcome at the time of presentation. After that, palliative treatment with the intent of prolonging survival while maintaining quality of life is important. There are numerous experimental therapies being studied to try to improve the outcomes in this devastating disease of cholangiocarcinoma. And we hope that we'll start to see bright lights similar to what's being developed in hepatocellular carcinoma. So Patrick and the organizing committee, thank you again for another very informative and enjoyable PHC 2021. Of course, we hope to see everyone safe and healthy and next year in Paris for PHC 2022. Thank you very much.